join. Thank you. Oh, Diego, I see singing opera. That is a good one. That's exciting. That's exciting. I hope that comes through for you. Welcome everyone as you come into the webinar. Thank you for joining us today. We have fun icebreaker question for you. If you could instantly learn any skill or talent, what would it be? I said mine would be playing piano. I've seen singing opera. Fluent French. It's a good one. I think I know 2 words. Learn how to play the piano or guitar. Yes, you're with me on that on the piano. Violin wouldn't be bad also. Yes, so everyone, as you come in, kindly respond to the icebreaker question and let us know if you could instantly learn any skill or talent, what would it be? Hi, everyone, and welcome to today's Digital Squared Global Goods webinar series. And as we wait for people to join in, there's a fun icebreaker question for you. If you could instantly learn any skill or talent, what would it be? You can have the first few minutes to look at that. You can see drawing, painting, drums, perfect rhythm. Oh, okay, it seems like it's all towards the artistic side of things, the writing. We'll give about 2 minutes for others to join, then we can kick off. In the meantime, feel free to continue answering the icebreaker question. If you could instantly learn any skill or talent, what would it be? Okay, thank you everybody for joining. Thank you for joining our Global Goods webinar, which is a third in this series of introducing content global goods. So to begin the webinar, we'll just start you off with a short poll question. We can have the first few minutes to answer that. So what we'd like to know is, how would you rate your overall knowledge of global goods? Not much, I know quite a bit, or I know all about global goods. Kindly respond to the poll, and we can begin soon after. Thank you. Again, for those of you who are joining, we have a quick poll question for you. How would you rate your overall knowledge of global goods? Not much, you know quite a bit, or you know all about global goods? Please let me know. Again, welcome everybody to this series of Digital Square Global Goods, where we're introducing our new content, Global Goods. We have a quick poll question for you. How would you rate your overall knowledge of global goods? Not much, I know quite a bit, or I know all about global goods. Kindly let us know. Okay, I believe we can close the poll now and get started. Thank you for your responses to the poll question on how you'd rate your average knowledge of global goods. About 46% say not much, 49% quite a bit, and 5% I know everything. So want to move some of these lines to the other. Thank you for responding to that. So this is the third series in introducing the new content, Global Goods. Welcome everybody. We want to go into deep diving into our global goods and understand the new content, Global Goods. So the agenda for today will begin with a brief introduction on content, Global Goods, and then we'll dive into WHO Smart Guidelines as one of the global goods, content, Global Goods, and finish up with FHIR 7.5. So to begin, I'll hand it over to Linda, who will take us through an introduction to content, Global Goods. Over to you, Linda.
Yeah, thanks, Luciana, and welcome everyone. I'm very pleased to see so many of you on the call today. I'm hoping that for those of you who are not so familiar with global goods, that by the end of this, you'll have a much better idea of what they are and what they can provide. So over the last few years, Digital Square has been producing our Global Goods Guidebook, which is a valuable resource really aimed at anyone looking to adapt or evaluate or implement open source technologies for health. And some of the characteristics of a global good is that, first of all, it isn't available under an open source license. It must be focused on the health domain. And it has some degree of maturity and some level of uptake. So these are not brand new innovations, but something that has an existing footprint. So they're backed by a strong community with clear governance structures, ideally funded by multiple sources, and show the ability to scale and have demonstrated use and effectiveness. And one of the things that we were very excited to launch at the beginning of 2024 was our interactive Global Goods Guidebook, which you can see there on the screen. I'll drop the link in the chat for you in a minute. But as part of that process, we also ran a call to identify specifically content global goods. And those are the special technologies that we have been showcasing over the last couple of months. And we're very excited today to be showcasing two of those, which are the WHO Smart Guidelines and HL7 FHIR. So I'm going to hand back to you, Luciana, to get us started.
Thank you. Thank you so much for that, Linda. So to begin us, our first esteemed speaker is Nadja. I hope I pronounced that properly. She's the technical officer at WHO, and her hobbies include pottery. That's a nice new skill to have. So she'll be taking us through WHO Smart Guidelines. So without further ado, I will hand over to you the screen now, and you can let us know more about yourself and take us through the Smart Guidelines. Thank you.
Great, thanks, Luciana. So I'll share my screen now, and please let me know when you do see it. Can everyone see that?
Yes, we can see it.
Okay, great. So I'll just dive right in. So I think just to set the stage that as WHO, we do have the global strategy on digital health, which was approved and agreed upon by member states in 2020. And one of the key things was really about improving health for everyone everywhere to accelerate, and by accelerating the adoption of digital health solutions. And one of the key strategic objectives that I do want to highlight here, there are 4 of them. One of the key ones is advocating for person-centered health systems that are enabled by digital health. And this is really where the smart guidelines of work comes in to try and support. And so what we foresee in terms of a digitized future is really moving away from this idea that health workers are only responsible for reporting. I think there's been a history whereby a lot of digital tools have been built for reporting and getting data at the individual level, but still for reporting rather than for actually providing person-centered care. So what we've seen now in a lot of countries is, although there's been an increased adoption of digital tools, now there's this other awkward level of redundant data entry. So you still have the paper systems because not all systems are fully digital. The health workers still have to report on their paper registers, but then now they also have to still sometimes input data into an electronic medical record system, but then also manually aggregate that data from the EMR and then input that aggregate number into a DHIS2 reporting system. And because of this lack of interoperability, there's really this problem and disparate level of work that health workers still have to do. So we want to move away from that and really ensure that there's this increased ability to uptake evidence-based guidelines at the point of care to provide higher quality of care, and for the health worker to really focus on providing that care rather than the day-to-day workload that they now are inundated with when it comes to reporting and things like that. And so we want to ensure that with a digital future, there's also reduced cost and time required to develop and adopt these digital solutions. I think we've seen a lot of technical debt that countries have taken on because of this redundant level of solutioning and also the lack of interoperability across these solutions. And then also ensure that the solutions are country-led and there's local production. Because I think the other big thing that we have to acknowledge is that digital health development is an aspect of economic development for a lot of countries as well. So the need for job creation, having a local economy to support that local production in the health tech sector is really critical for sustainability. So we want to move away from the current model of engagement whereby a lot of digital solutions are developed in the global north and then supported remotely or having kind of outposts in countries to whereby we have a healthy health technology sector in countries and in regions. And then lastly, the digital future and collecting once and using many times. So going back to the health worker only needing to focus on providing care and collecting the data that they need for care and having the decision support that would help them provide better quality of care. But then as a byproduct of that is where the secondary data use and reporting would come in to allow for this greater access and autonomy over that process, and then also ensuring that individuals can have access to that data as well through the use of interoperability standards. And so for the smart guidance work, we really are targeting this new group of stakeholders. So either the technology partners that have been hired by ministries of health, or even the digital health teams within ministries of health to ensure that these digital technologies are strengthened, are quality, enterprise quality, and then are able to be easily maintained in a non-costly way. So the smart guidelines content intervenes at really critical steps of the software development lifecycle, whereby, as you probably know, the software development lifecycle has the gathering user requirement stage, then you go through design, adaptation, development, then you conduct testing and training and rollout of those digital tools. Then as you scale up, there's obviously going to be feedback, and then there's this continuous improvement cycle. So the smart guidelines is intended to provide a starting point at the gathering user requirement stage, as well as the design, adaptation, development stage, to really move away from these monolithic siloed data models based software systems to these building blocks that allow for greater focus on human-centered design, but then also allows for interoperability and reduced time to development so that there is more standardized data and logic that's being used across all these systems at the point of care. And so there is the Smart Guidelines framework, whereby there's 5 key layers. So one is the narrative layer of guidelines, which WHO already publishes, and we are working internally to help improve even at the narrative content layer to make that more precise, more operationalizable, by working with informaticians and involving them throughout the guidelines development process. But what you probably have heard of more often is actually our layer 2 content, which are the digital adaptation kits, which are essentially the requirements document. So this is where during the gathering user requirement stage, the digital adaptation kit can help provide a starting point for countries, or could provide a framework for countries for, say, health areas that we don't have a digital adaptation kit for yet, to ensure that they have all the documentation that's actually needed from their technology vendor for certain health areas, so that they do have all these things written out clearly. And then we have the machine readable guidelines, which I think colleagues from HO7 will go into a bit more what the FHIR standard is about. But the machine readable guidelines are intended to provide software agnostic documentation that leverages the FHIR standard to allow for interoperability based on the digital adaptation kit content to actually be used into systems. And then of course we have the 4th layer of the Smart Guidelines, which is reference software based on the content in the digital adaptation kits, as well as the machine readable guidelines, to ensure that countries also have a starting point at this stage. I think it's important to note, though, as WHO, we don't really focus too much on the executable layer, because we recognize that most of the use cases is that countries will already have a system in place, and it's more about updating those systems. And so the executable layer is really more just a reference software that some countries can leverage if they need to. And then as we move forward, we also want to have the dynamic guidelines, which we are exploring right now on, for example, how to use AI-based decision support based on data collected from individual level systems at the point of care, and also potentially to inform the guidelines development themselves. So for example, right now, guidelines are based on systematic reviews, expert review panels, and they come up with a consensus-based recommendation. But a future in which we could use the information collected directly from countries, for example, understanding what recommendations they've adapted, if we could use that to also inform the narrative content of the guidelines and the science behind that, would be really valuable moving forward. And just a quick example of what this looks like for immunization. So we have the immunization recommendation tables, which are the standard schedules that WHO recommends for routine and non-routine immunizations, but also, of course, the guidance for immunization program managers. So this allows the analysis and use of health facility data, so things that individual program managers would need to understand when managing their immunization program. And we bring these together into a consolidated digital adaptation kit. So this has the workflows, data dictionaries, user scenarios, clinical decision support logic structured using the decision modeling notation DMN standard. And then also the indicator calculation based off of the data dictionary, and then a list of functional and non-functional requirements. And at this stage, we also provide the mappings to ICD codes in the data dictionary, as well as other semantic standards, so that there is the semantic interoperability piece available already. But then we take that and we have the machine readable guidelines. So there would be a FHIR implementation guide on immunizations that translates the content in the digital adaptation kit into these FHIR resources and into the clinical quality language or CQL statements that then are used for clinical decision support. And then we have an executable reference software that's currently being developed as well, again, using the content from the machine readable guidelines, but also building off of the Google FHIR software development kits for Android so that it can be used natively. And then we have, not yet, but a future whereby we envision the dynamic guidance for immunizations, and this is where things like precision public health can come in for surveillance as well. And so I think I briefly touched upon this already, but in terms of the scenarios of use for the Smart Guidelines, if a digital system doesn't exist yet, they really provide a starting point and a benchmark that countries can use to reduce the time and resources it needs to do the requirements gathering process as well as to do the FHIR content development. But of course, if systems are already established, it allows for the update of existing systems to ensure it does adhere to the latest WHO guidelines, because of course, WHO guidelines are updated all the time as the science is updated, but then also a facilitated approach to adopt interoperability standards in either a FHIR native or a FHIR hybrid approach. But of course, if countries are not yet ready for digital for whatever reason, or there's other blockers that they need to manage, the digital adaptation kits can also be used to inform the update of existing paper registers and decision support tools, because they are structured in a way that is beyond narrative, so then it allows for a bit more easy translation into operationalizing that content at the health facility or point of care. And so this really allows for the improvement of analog processes as well, independent of digital. And so we envision that every single layer of these guidelines would be adapted in countries, so that countries have their own version of the smart guidelines essentially, so that they can use that as a package to implement into their systems, but also have the documentation necessary to continue to maintain the systems, and also potentially a future whereby they can use that to benchmark and sort of test and sandbox other solutions that would come into the country so that there is that healthy environment, but also a way to regulate the content that's actually going into the system. And so hopefully we do see a global movement towards, we are already seeing a global movement towards countries adopting this approach, regardless of whether or not WHO has the actual smart guidelines content readily available. Because of course, we have it for some areas, like antenatal care, family planning, HIV, child health and humanitarian emergencies, and DB already published. But of course, we do hope to eventually cover all areas of primary health care. And so if there's other areas, for example, with NCDs that countries have prioritized, there's the smart guidelines approach that they can still leverage. And we have seen countries leveraging the digital adaptation kit templates, for example, or even the L3 machine readable guideline templates for their own uses as well. And then I think just to quickly share too, we recognize that the smart guidelines comes into a much larger ecosystem of content, recommendations, and tools that countries need to use. And so to just couch this in the digital implementation investment guide framework of how digital is implemented in countries, the smart guidelines really comes in at the determining the health content requirement stage, ensuring that the health content is evidence-based and is structured in a way that can be used across any system. And then just lastly, the way we see this is that the smart guidelines are intended to help inform the health worker point of service system, but then this framework can also be applied to individual level systems. And so we do have, as WHO was called, the Global Digital Health Certification Network, which I won't really go into now, but of course, if anyone has questions, please feel free to reach out. But then it allows for individuals to have access to their own personal records and pull that information essentially from the point of service system, so that they have sort of what's called a patient summary of key information that they can bring around wherever they are. So things like vaccination records, allergies, medications, and so forth. So I'll end here and just share that we do have a growing and open community of people interested in the smart guidelines work. So specifically, we have the authoring and implementing machine readable guidelines call every Monday at 2 p.m. GMT or 3 p.m. Geneva time. If you're interested, please feel free to reach out to smart@who.int to be added to the calendar invite. And then we also are working very closely with Google, of course, to develop the Android FHIR SDK. And there's a developers call for that at 8:30 a.m. Or this might have changed actually. But again, if you're interested in that, please do reach out to the Android FHIR at Google email to join those developers call. And we also have a channel on the Zulip chat that's used in the FHIR community for this. So I know I have another presenter from the HL7 FHIR community coming up next, so I'll just end here, and of course happy to answer any questions. Thanks.
Thank you, Nat, for that presentation. So we'll open it up to any questions around WHO Smart Guidelines. I have a question for you, Nat. What would you say is the main advantage of using digital adaptation?
I think the main advantage is actually more so the process of adapting the content and the framework that the digital adaptation kits provide for documentation. Of course, the content itself is WHO recommendations, but countries also go through a process of adapting that anyways, which is understandable. And we do see countries sometimes take the content wholesale and use that in their systems. But more importantly, what we've seen is that the digital adaptation kits really force countries who are developing digital solutions to bring all the right stakeholders together. So for example, we see sometimes that there are countries that have a EMR that has been deployed, but it's been deployed just for the purposes of data reporting, not so much for the health workers. So the digital adaptation kits, because they outline and clearly highlight the use of user scenarios and user personas, it requires the ministry to actually reach out to health workers who are providing the point of care and inputting this data at that point of care to really inform the content of the digital adaptation kits for their country and inform the design of their systems. And then it also forces that documentation amongst vendors, because I think what we've seen also very widely is that vendors will have a solution that they've successfully sold to a Ministry of Health, but then if there needs to be an update and the Ministry of Health wants to do it themselves, they don't actually know what's already in the system. And so the digital adaptation kits provides that framework of exactly what needs to be asked from the vendors. And so I think it's multifold, I would say, but I think the methodology, the framework, and way of approaching digital health solutions has been the biggest benefit I've seen.
Thank you for that response. And I agree, looking at SMART guidelines and being a BA by profession, I found it the most exhaustive requirements documents I've seen thus far. Okay, thank you. Anybody else? Does anyone have questions? Okay, if you have any other questions, you can still hold them off to the end of the webinar, the end of the webinar. So next we have Diego Kaminka, who is the HL7 Deputy Chief Standards Implementation Officer, also known as DCSIO at HL7 International. And he will be taking us to HL7 5. So over to you, Diego.
Can you see my screen?
Yes, we can see the screen.
Perfect. Thank you very much. I was already introduced, so I will not say my name again. I'm talking to you on behalf of Dan Breman, who is the Chief Standard Development Officer, who cannot be here, so I will be covering. If I don't know how much time I have. I have 28 slides, so I will try to finish in half an hour, but let's see how it goes. First, thanking you for joining us on our interoperability adventure. It's very nice to have larger communities all around the world joining us. And you will see our global outreach later, but it's expanding every year. Even when we did a lot of progress in the last 25 years, people are still moving faster than their health information. So both in well-resourced and low-resourced environments, people routinely goes cross-care settings, cross-organizational settings, and even cross-jurisdictional boundaries with their health information that will not follow them. So a big challenge that we are trying to solve from the last 30 years is to connect these separate data systems in that each system often represents the same kinds of health data in different ways. So different formats for the data, different codes for the same test or medication. So those challenges make it extremely difficult to achieve meaningful interoperability at scale. This is our mission. This is what we want to achieve, and this is what we are trying to achieve, especially with FHIR. I just was checking the chat. So FHIR is our modern interoperability framework, has won the backing of governments, healthcare providers, software vendors, and a fast-growing community of implementers. And you are an important part of this vibrant FHIR community. At HL7, we believe better health shouldn't be limited by geographic, national, socioeconomic, or other boundaries. It's why we are so passionate about FHIR as a global good and why FHIR has been placed in the public domain from the beginning under CCO license. But we want to emphasize that the significance goes beyond the standards or even the technical innovations that implement them. Anyone, anywhere is free to use FHIR however they wish. The freedoms enabled by FHIR reduce barriers to opportunity around the world. This kind of free goes far beyond cost. It's the freedom to create and the freedom to build on, the freedom to change the world as it is now. So Dan has changed the acronym FAST Healthcare Interoperability Resources to freedom to harness global interoperability wisdom, implement, inspect, and improve, redistribute refinements, helping others. So you're free to actually share the knowledge that everyone else has created, implement, inspect, and improve the artifact that we create for interoperability, and redistribute your refinements and helping others. And from our perspective, this is the true beauty of FHIR. So how we had advanced our digital health promise. We started 3 years ago, this team with the HSM International 3-year plan based on focus, agility, global relevance, community, and sustainability. We created 2 divisions, the implementation division and the standard development division. Both work together, but had different focus. And as you can see here, we have a very specific way to create and ballot standards because our standards are voted on by the community. So we begin with the community and use case building. Then we have some project planning and integration into standards process. Then the specific standard development process where we create the specification, ballot it, resolve any problems with the ballot or any negative ballots, and finally publish. But while we are doing that, we added some specific steps that guarantee that these standards are really usable. Those are reference implementation developments, that this is software that implements the standard at some percentage, usually the most the better, and can be used by testers and by developers to see what their system should do and how. And that is also included in testing events and giving feedback back to the standard developers to improve the specifications. And finally, we have a whole range of services. It's best practices playbooks, educational materials and courses, putting the reference implementations in our own ecosystem to try and test, and also pilot projects. So some of them are specific of the standard development division, which are in yellow. Some of them are more specific for implementation, which are in blue, and the others in green are mixed implementation and development. But it's not just our divisions, it's the community. It's about the community and working together globally to achieve these goals. This is our global outreach. These are the countries where we have affiliates all over the world. And from the last 2 years, we added regional partners, both in Africa and in Asia and Southeast Asia. Our regional partner for Africa is Helena, covering 14 countries in Africa. And our regional partner for Southeast Asia is AHIN, Asia eHealth Information Network, covering almost 18 countries in Southeast Asia. We also have collaborations with associations, standards developers, societies, and other sojourners in the global community creating public goods. We also have our accelerator program. These are organizations in the US and globally solving some problems with our FHIR API products. And last but not least, we have a collaboration agreement with WHO, with the World Health Organization, to support adoption of open interoperability standards. In this moment, we are working on making all our publishing tools capable to manage all the languages that the WHO supports, and also in giving support for ICD-11 to all our terminology services. We need to remember that interoperability is a team sport. This is a picture of the last MedInfo Congress, where we were together with all the other standards development organizations representatives. This is the first one is done, then Ed Hammond and people from SNOMED, from Loing, etc. So these are all the SDOs together working towards global interoperability. Some of the use of FHIR around the world, diverse applications. You just heard from Nat about the FHIR SDK for Android, but all the cloud providers are express their use of FHIR as the data sharing mechanism. And one of the biggest projects in the world is FHIR for IBDM in India. They have a very big implementation. I think it's the biggest in the world, maybe followed by the implementation in Indonesia, the Satu Tekan project, which has 2 million patients registered. But I think IBDM has 500 million patients registered. Usually, by giving the patient access to their own data and giving clinicians access to the data that other clinicians generate. This is from the CDC African Union Task Force, recommended that all new implementations and digital health systems improvements use FHIR as the primary mechanisms for data exchange. This is from 1 year ago, I think. It's a very bold vision and very important to move forward. About the global goods, FHIR was approved as a global good last year by Digital Square, along with others. And here are some of them. These are all projects that use FHIR as their exchange mechanism. So 30 of the 36 global goods recognized by Digital Square use FHIR as their the exchange mechanism. And these are the page explaining how they use FHIR as their exchange mechanism. These are Open MRS, AHRS, and Global Open Facility Registry. These are just examples, but each product in the global good registry has a specific way of expressing interoperability, but all of them are using FHIR. And also FHIR was recognized as a content global good. And my question is, global good for what? So what's the use of FHIR in these products, or generally in any product that attempts healthcare interoperability? And my own answer to this is we need to always solve the last part of this diagram. You see here that we have 4 rows. The last 2 rows always need to be solved. So you need to know who your organizations are, who your clinicians are, or your caretakers, who are the patients, and how to identify them in a patient registry, a way to record consent, or has this patient allowed the use to his or her data and sharing it, allow authorization and authentication. So we need to know if this patient, this user really has access to the system and whether the user can see this specific patient information or edit or add information. We need to access terminology. How do you know that this is the code for diabetes and not other code? How can we access SNOMED or LOINC or ICD-11 or 10 in the same way? How can I use terminology services all in the same way? How can I know if the artifacts that I'm exchanging for a specific domain or use case are correct? That's called validation. So we need to know for this specific use case, which are the constraints. This is not a very difficult subject. It's just how is the patient name formed? Which are the identifiers for the patient? Which are the identifiers and correct designation for the address of the patient? Which is the correct format for the phone? How do we know that the codes we use for medications are aligned with our definitions? That's constraints. And also extensions. How can I add something that is not in the base standard because my country needs it or because my own process or project needs it? That's called extension. And then transport. How do I go from one place to the other in a standard way, in a secure way? And finally, how do I keep a log of everything that happened? Who created which record? Who accessed each record? Is there any clinician that accessed information that it should not be accessing? So that's the audit log and trail. So for the first two levels in the bottom, there is a FHIR spec or resource or something that will tell you how to do it using FHIR. This is the first time in history that we can use the same standard for almost everything. I think almost because if you are exchanging images, you will use a different set of standards like DICOM. But if you are exchanging just granular data, not images, you can use FHIR for everything. And once you have these two first rows solved, you can use FHIR for public health reporting, for clinical decision support, for exchanging documents and create your shared EHRs based on documents. You can exchange granular clinical information like allergies, lab results, etc. You can exchange referrals and continuity of care, the answer to those referrals. You can go from the diagnostic order to the report in labs or image and diagnostic image. You can cover the whole workflow in pharmacy, from e-prescription to dispense to administration, and you can create immunization cards. But these are just examples. If you have the 8 lines boxes below, you will be able to tackle any digital health products using FHIR. So how do we enable the virtuous cycle of standards advancement? And this is what I call the FHIR toolbox. It's not just the core spec. The core spec, the core content, is that how we define things in FHIR. What is a patient? What elements are in a patient? What is an observation, a lab observation, or imaging observation? How we define the elements inside. And there are versions of FHIR like release 4, 4B, it's 5, and finally release 6 next year. And we also define the API syntax, how to create a new patient, how do we update the patient, how we can search a patient. But that's not all. Our toolbox covers these 11 needs for your project. The second need is how to profile and publish your own implementation guide. We see the SMART guidelines as a specific implementation guide, how we use FHIR for this specific domain, because it's not a national guide, it's for the entire world. So we publish some tools to, based on the core spec, create new specs. And those tools are called FHIR and the IG publisher. We are now working with WHO on internationalization of the IG publisher, so it supports all the 6 languages that the WHO requires. Then after you have your spec, our core spec, and you have profiled the spec, you have your national or domain-based specification, national-based guide or domain-specific based guide. And then based on all of that, you have the other tools. One of them is Smart on FHIR. It allows to control authentication and authorization, and also to launch your own application inside of other applications. That's Smart on FHIR scope. Then you have CDS hooks, how you can ask for a clinical decision support tool to apply its knowledge to your own data, but it doesn't matter which EHR you are using or which clinical decision support you are using, you will use the exact same call, and you will have the exact same format back with the decision, with the actual knowledge. So that's another standard called CDS hook that allows you to do that. Any EHR to any clinical decision support system with the same API. Then we have CQL, Clinical Quality Language, and Clinical Quality Language allows you to extract and process information and apply knowledge in any FHIR data server. So you just create your logic, and you can apply your logic to extract information from any FHIR server. This doesn't mean that you don't need to have your terminology right and your structure right, because if your terminology is not right and your structure is not right, you will not be able to apply any clinical language or any other language to your data. Then we have the questionnaires, the FHIR questionnaires, and a nice specific guide that allows a better use of the questionnaires. These are templates to get information from patients and from clinicians. Then we have bulk FHIR that you can use when you need to exchange several thousands or million records from one system to the other. So usually when you use the FHIR API, you will use that for synchronous data, for a specific patient data going back and forth. But if you need to exchange hundreds or thousands of millions of records, then you will use bulk FHIR, asynchronous services. You will just ask the server to get you what you need, and you will wait until it's ready. Then the FHIR terminology services, allowing you to access any global terminology using API-based calls, the same API calls it regardless of the actual server. Then we have a new SQL-based standardized view for FHIR resources called SQL on FHIR, which is in the works. We just released the first specification last month. And finally, what we call the definitional resources, where you can define activities, care plans, and measures. And you can use these resources to apply knowledge to a specific set of information represented as FHIR resources. An example of this is the SMART guidelines that you discussed previously. The SMART guidelines use to achieve its goals the core spec. Currently, they are using FHIR Release 4, the profiling and publishing tools, FSH plus the IG publisher. They have created a domain-based specification or several domain-based specifications, as many as guidelines they have created: antenatal care, immunization, tuberculosis, etc. They use CDS hooks to standardize the clinical decision support API calls. They use the CQL clinical quality language to represent the knowledge and the decisions for each region or country. How can we configure the SMART guideline for this specific country. You have to change the CQL, the clinical quality language specific for that project. They use questionnaires, heavily use of questionnaires, because most of the information may come from a phone where the only thing they can do is just answer some questions, which is a very easy thing to do with FHIR questionnaires. They use FHIR terminology services to access the terminology, including ICD-11, SOMED, or any other. And finally, definitional resource to represent this SMART guidelines knowledge in FHIR resources. So they define the activities, what to do in this case, if this patient has these specific conditions or hasn't been treated for this specific condition or has specific results. Those are care plans. And also measures. How can I know how many patients I attended for those patients, how many have been treated correctly. So these are the use, at least from my viewpoint, that the SMART guidelines are doing from the FHIR artifacts or from the FHIR toolbox. About our publishing process, we have just in the auto-build infrastructure, which is built every day from the current specs that everyone is publishing, we have 475 domain-specific or country-specific implementation guides. In 2023, we have automatic build for Australia, Belgium, Canada, Chile, Denmark, Europe, Estonia, Finland, Italy, Portugal, Netherlands, New Zealand, Sweden, Switzerland, and the United Kingdom, but we are growing every month who is using our infrastructure. These are the ways that you can use to validate a resource. We have a system to validate, but you can also embed it in your own systems to know that the information you are exchanging to your API is correct. And this is an example of IPS, International Patient Summary, which is also used in the SMART guidelines as part of the content definition, because this is a specification that is used worldwide to create a very small, very mature brief of the patient status, including allergies, medications, problems, and immunizations as mandatory, and other things that you can also exchange in the same format. And most of the implementation guides that we published last year have a corresponding reference implementation software. So what you can see here is the actual reference for this specification. So we publish the how to do it along with the what is this supposed to do. So you can test your software against our implementation. And this year we introduced the HL7 FHIR Foundry. You can find the Foundry at https://foundry.hl7.org, where you can locate, try, and maintain reference implementations for use by your implementers. So with this a gallery with solutions that you can, these are not production solutions. These are production, so you can test the reference implementations and see what they are supposed to do and how do they do it. There's a gallery with, we now have 60 reference implementations where we are growing every month. We also have our way of growing global FHIR capacity. We have 3 programs. One is credentialing, where you can showcase your FHIR knowledge and help hires find qualified people. We released this year a new certification exam called the HL7 FHIR Foundational. And coming up next year, we will have our first advanced test, the HL7 FHIR Advanced Developer, which will allow you to prove that you can create clients or servers for FHIR. We also have a program called Certified Educator, where you can demonstrate your expertise in FHIR education. and help education consumers recognize quality. And we are also expanding training opportunities for the industry with our education partners. And I think will be my last slide. HL7 International is FHIR's home, where it grows and gets nurtured. And HL7 FHIR is you. Educate, engage, and enable. And that's my last slides, and I thank you very much for your attention.
Thank you very much, Diego, for taking us through that. I can open the floor now for any questions. Feel free to put your questions on chat or come off mute. Well, thank you for the presentation. It was quite interesting to even look at the connection between HL7 FHIR and SMART guidelines. And it's quite interesting to look at how your ideas around growing capacity. I have a question for you. How long would you say it would take a mid-level developer to learn how to use FHIR, assuming there's a practical case for them to focus?
Well, something between 2 weeks and a year. Because in 2 weeks, you can start working with basic requests. In fact, I did that in my last visit to Kenya. We did a workshop, and in 5 days, the developers were actually creating their own IG and exchanging information for a FHIR server. But that's basic FHIR. What happens if you need to also implement? You saw all the squares that I created for you. The squares in the bottom half are infrastructure pieces. So if you don't have your infrastructure pieces in place, the client developer is not able to do much stuff. You cannot ask your client developer to create a terminology server. So we need to be very aware that we need the infrastructure part in place. And I think we are doing that using open source, like open OCL for terminology, or some specific software that will act as master patient index or master provider index. So we can get our developers to focus specifically on the problem at hand. And this also applies to the SMART guidelines. So we need very strong infrastructure to get our developers focus on the client side so they can be fast. If we make them do the server side, the platform side, it will take years. So I think we need to leverage what we have already in place. And that's why I think the Global Goods program is very important. We need to use open source and use open source that is good to solve the big problems or the complex problems, and then use our developers to just focus on our own domain and our own specific problems. And I think that with a few months, a first introduction in maybe 1 or 2 months, they are able to work with these servers and with the FHIR resources in their own apps. I think I tried to answer your question.
Yes, you've quite answered it. Thank you so much. As Digital Square, we always advocate for FHIR, and it's been exciting to actually see the steady growth in adapting FHIR. So thank you for that. On chat, I can see a question to you, to Nat, actually regarding the WHO SMART guidelines. In the GitHub, can we find that the immunization doc will be published soon? Do you already have a date for us?
We don't have an exact date right now. It's currently going through editing. So we foresee probably either beginning of, end of the summer, beginning of the fall when the DAC should be ready. But we'll be sure to make an announcement when it is.
Okay, I think we're all excited waiting for that immunization doc. But yes, thank you both for your presentation. That was very valuable. For all the attendees, we'd also love to hear from you about any topics you'd like us to cover during this webinar series. Please feel free to share your suggestions in the chat. So going forward, we want to just give you a small announcement on our next our next webinar series, which is where we'll be looking to answer this question. How do digital health services include or exclude people marginalized by language? And what can be done to reduce the digital language? So this will be presented by FHIR Global, who are an NGO focused on improving communication and language access for marginalized communities globally. Some of the FHIR Global's research insights are what you see highlighted in the screen. So kindly, we'll send out those invites and join us on the webinar to explore practical steps for making this digital health services more inclusive. For those of you asking about the recordings and the presentations will be shared, and all the links that will guide you to understand and learn more in regards to HL7 FHIR and SMART guidelines. And also feel free to join the community so you can have continuous growth with them. I see a comment here. What are your thoughts on using data warehouse that are not open source? What if a country is mostly using proprietary ones? Should we adapt to that instead? Our end goal is for better adoption. I'm not sure if either Diego.
Fits for me. My answer is, while I prefer open source for low and medium income countries, if a country is using a proprietary tool, the only thing I ask is that they use standard content for the exchange. So at least have them use FHIR as the input or output for their software. So if we want to replace that software, we can. The problem when using proprietary software with proprietary interface is that they are very difficult to replace. And you should be free to replace your software. Freedom is important. I don't know if I answered the question.
Yeah, did that answer your question, Mark? Okay, there's another question. I'm not sure this is where to ask, but is something being done to handle issue criteria dependencies on FHIR sometimes?
I'm answering the other question. The other question, the best way to join the community is chat.phir.org. And if you are interested in the SMART guidelines, you should join the calls that Nat detailed before. About the circular dependencies, just send me an email and I can help you with that. That's my email.
Okay, so thank you all for joining today. I see we're at the top of the hour. All the artifacts for this webinar will be shared with you shortly. And also look out for the invitation for FHIR Global for our next webinar. Thank you again for joining, and thank you, Diego and Nat, for taking us through your presentations today. This has been very valuable. Have a great rest of your day. Bye.
Good. Thank you.
Thanks all. Bye.